Hopefully, by the end of this talk, you will learn about complications-based approach to guide treatment and intensity of treatment of obesity, review the guidelines on lifestyle modification and use of pharmacotherapy in managing obesity, and examine the controversial topic on whether we need to eat twice a day, 3 times a day, or 6 times a day, and whether we need to eat breakfast all the time or skip lunch or eat prepackaged food, and what type of behavior do we need to teach our patient and in order to prevent the development of obesity, and what's the relationship between intelligence of a person to development of obesity later in life. I'm an investigator on the effects of liraglutide on cardiovascular event in type 2 diabetics. So this liraglutide will be mentioned here for the use of treatment for obesity. So I'll start with a case presentation. I have a 52-year-old female who was referred for morbid obesity. She said that she was obese all of her adult life, and she had a Roux-en-Y gastric bypass surgery in 2004. Her pre-surgery weight was 450 pounds, and she lost about 200 pounds a year after surgery. 11 years later, when she came to see me, she weighed 330 pounds, so she has regained about 80 pounds. Her BMI was 56, and I gave her the usual treatment that we were taught to give, which is lifestyle modification, including diet therapy. She talked with our dietitian for 30 to 45 minutes. And I did the work up to rule out Cushing's syndrome, hypothyroidism, and polycystic ovary disease, which was all negative. 3 months later, with our instruction, she gained 26 pounds, so she was already weighing 356 pounds. So I put her on medical therapy using Phentermine at 30 milligram QD. So she lost some weight, and then by next visit, I continue her up to 6 months of therapy for Phentermine. So she maintained the same weight in 6-month period. Then the latest visit, she was off Phentermine for 3 months. She has regained all her weight and plus more than before therapy. This is actually very typical of obese patients. The recidivism rate for gaining weight that they have lost is actually very quick. In general, we use body mass index as a measure of obesity. So this is calculated by measuring weight divided by height in square meter, or we can use their waist circumference, more than 40 inches in men and more than 35 inches in women. Obesity is classified into either patient is obesity class 1 when their BMI is above 30, around 30 to 34.9. Class 2 is BMI of 35 to 39.9, and extreme obesity is BMI of more than 40. There are other ways to measure obesity, including measurement of skin thickness in the subscapular, triceps, biceps, and suprailiac area, or measuring the waist and hip circumference. Normal waist to hip ratio is less than 0.9 for women and less than 1 for men. In terms of skin thickness, it should be less than 4 centimeters in males and less than 5 centimeters in female. Other ways to measure obesity is use of densitometry, which we usually do not do, but electric impedance measurement is available in the HCOC clinic on the 5th floor. We also identify obese subjects based on the fat distribution, whether their fat accumulation is above or below the waistline. If their fat accumulation is above the waistline, then they have central obesity or apple-shaped obesity. And if their fat accumulation is below the waistline, they have the pear-shaped obesity. This is more metabolically damaging than this type of obesity. In fact, a lot of people with BMI of 50 or so, if their fat distribution is predominantly gynecoid, they do not develop diabetes. Unfortunately, most of the people that we see in the clinic are morbidly obese, and they have the apple-shaped type of obesity, fat distribution. We know that from Framingham study, which is almost 75 years of tracking the 4 generations of people in Framingham, Massachusetts, that obesity is correlated significantly with many chronic diseases, including diabetes. For example, in type 2 diabetics, only 15% of patients have BMI less than 25. 30% have BMI between 25 to 30, and 55% of type 2 diabetics have BMI of over 30. This is also true on the cholesterol level for both males and females, and also on the degree of hypertension for both males and females. There are over 150 complications of the medical complications that has been identified that are associated with obesity, some of which include obstructive sleep apnea, non-alcoholic fatty liver disease, gallbladder disease, gynecologic abnormality like polycystic ovarian syndrome, osteoarthritis, skin problem, venous stasis, certain forms of cancer, pancreatitis. The big ones are coronary artery disease, diabetes, dyslipidemia, hypertension, stroke, cataract, and idiopathic intracranial hypertension. The rate of obesity in most of states are between 30 to 34.9%, except for Louisiana, Mississippi, Alabama, and West Virginia, which have a rate of over 35%. 1/3 of the U.S. population is obese, and 2/3 is overweight or obese. And the cost is very high because 40% of the healthcare expenditure in the United States is related to chronic diseases. And most of the conditions of chronic diseases are associated with obesity. What are the causes of obesity? Some of them are pretty obvious, like lack of energy balance. We eat more than we need to, and we exercise very little. Genes and family history, certain endocrine conditions, drugs like steroids, emotional factors like people with schizophrenia or depression tends to get obese, alcoholism, smoking cessation, pregnancy. If a woman does not lose her pregnant weight, and she will accumulate all the weight that she gained each time she gets pregnant. Lack of sleep, an inactive lifestyle, work schedule, which we all understand, lack of access to healthy food, food advertising. Now it's no longer on television, but mostly through social media in order to reach children. Lack of neighborhood sidewalks and safe places for recreation. So how do we treat obesity? Different medical organizations have different recommendations. There's the National Heart-Lung Institute has convened a group of people in order to give recommendations on how to deal with this condition, and they try to answer these 5 questions. I'll give you the specific of their effort after 5 years of work. The Endocrine Society recommend medications treatment immediately for patients with who are obese, and the AACE, that's American Association of Clinical Endocrinologists, suggesting complication-based evaluation and treatment of obesity, while the British system wants to go straight to bariatric surgery, which is the most effective treatment. However, only 1% of obese subjects undergo bariatric surgery. After 5 years of work, the National Heart, Lung, and Blood Institute recommended a lifestyle treatment for most people with obesity. This includes dietary counseling, increased physical activity, and behavior changes, and pharmacotherapy for people with BMI above 30, and surgery for people with BMI above 30, but only laparoscopic gastric banding is recommended. This is what the Medicare will cover. The Canadian system categorized the treatment based on the complications of obesity. So stage 1 is when they have subclinical risk factors like prediabetes, metabolic syndrome, non-alcoholic fatty liver disease, and so on. Stage 2 is when they already have the established disease like type 2 diabetes, hypertension, sleep apnea. Stage 3 is when you have already organ damage like myocardial infarction, heart failure, stroke, diabetes, vascular complications. And stage 4 is if they are disabled already. So there is an increasing degree and intensity of treatment depending on the number of complications that they have. I'm not sure that anybody can see this, but this is the schema suggestion from American Association of Clinical Endocrinologists to intensify the treatment based on the degree of complications. For example, on the cardiometabolic end, if the patient has some of the features of metabolic syndrome, like high waist circumference, high blood pressure, or reduced HDL and high triglyceride, they need to be on lifestyle modification with and without medication. If now they have 3 of the 4 risk factors of metabolic syndrome, or including impaired fasting glucose or impaired glucose tolerance, they need to be on intensive lifestyle modification with medication. And if they develop more of the risk factors for diabetes, in addition to medication and intense lifestyle modification, they need to surgery has to be considered. And if they develop diabetes and cardiovascular disease, for sure they need surgery. This same recommendation has been given for mechanical dysfunction that occurs with obesity, including the degree of obstructive sleep apnea, reflux, gastroesophageal reflux, osteoarthritis, and immobility. The biggest problem is the economic cost that the society is paying for obesity. 20 years ago, these are the disability rate that occurs with healthy subjects, overweight subjects, and obese subjects. About 10 to 12% of people who are obese are disabled. But that was 20 years ago. The degree of obesity has been increasing by 74% for the past 20 years. So now the statistics has changed significantly. The orange bar are the people who are disabled and obese, and the working people, the blue bars are the ones who are working and are obese. And you can see in every year between 2009 to 2013 that there's a much higher rate of disabled people who are obese compared to working people who are obese. So increasingly, obesity is being used as a way to get their disability, and non-working people. So the cost to society is very high. What do they mean by lifestyle modification? I tried it on my patient. I recommended diet with dietitian consult, exercise. The patient said she cannot even walk to the mailbox to get her own mail. Behavioral therapy. I gave the usual list of recommendations for behavioral therapy, and it did not work. That's probably true in all of the clinical trials. For example, the diabetes prevention program was started by NIH, in which over 3,000 people with pre-diabetes, meaning they have impaired fasting glucose or impaired glucose tolerance, were enrolled in the study. And they were divided into lifestyle modification, intense lifestyle modification, then the medication, which was metformin, and it turns out it was the intense lifestyle modification that was the most effective in preventing the development of overt diabetes within 3 years. So about 50% of people who underwent intense lifestyle modification did not develop diabetes. There was a 50% rate decrease in development of diabetes over a 3-year period. So what do we mean by intense lifestyle modification? Usual diet, exercise, and behavioral therapy. The difference between lifestyle and intense lifestyle modification is there should be a weekly visit to a psychologist or a dietitian, and they have to participate in individual and group session. They get a behavioral modification curriculum, they get meal replacement, and they get pharmacotherapy. They need to visit the dietitian every week for 6 months. Then after that, they can do it every 2 weeks. It is only with somebody overlooking your dietary management and your weight loss effort that it works. So there's an issue of accountability. Big brother has to look over you before it will work. Our usual recommendation that we give a list of things that they have to do does not work. Again, this is the DPP program, Diabetes Program Prevention. It says the same thing. Weekly contact is necessary for 20 to 26 weeks. Most studies show that a minimum of 16 contacts is necessary in order to have effective weight loss. Now, in these days, internet or email contact and the use of social media usually is not as effective as direct personal contact, and this includes weekly weighing of the patient. What about behavioral therapy? They need to do their to record their food intake and physical activity by use of paper or electronic diaries. Again, weekly monitoring of weight, and they get structured curriculum of behavior change. There's a lot of psychotherapy involved on what is their weakness, etc., and regular feedback from an interventionist. So it's a very intense program before you expect any result. What do you mean by exercise? We know that exercise is not required to achieve weight loss. You cannot exercise yourself out of obesity. Only a caloric deficit is needed, but exercise is essential for weight maintenance. For example, the general recommendation is to reduce food intake by 500 kilocalories per day, so you can eliminate 2 of your 20 ounces soda, or alternatively, you can walk about 35 miles a week in order to lose that 1 pound. Therefore, it is a caloric deficit. It's always diet treatment that will work. So the general recommendation from the Institute of Medicine is to reduce the risk of chronic diseases in adulthood. We should engage in at least 30 minutes of moderate to moderate intensity physical activity above our usual activity at work or home on most of the days of the week. To help manage your weight and prevent gradual unhealthy weight gain that occurs in adulthood, we need to engage in at least 60 minutes of moderate to vigorous intensity activity on most days of the week. And to get actual weight loss, when you are already obese, you need to participate in at least 60 to 90 minutes of daily moderate to vigorous intensity physical activity. At the same time, you eat hypocaloric diet. We're a very lazy nation. About only 25% of people actually do the 30 minutes a day walk, moderate physical activity that's needed. And most of them are white people, followed by Asian and Pacific Islander, the non-Hispanic women, meaning most African American, and the Hispanic women are the least active people. And most of the activity that is suggested are aerobic exercise that will involve the large muscle group, meaning the arms and the legs, in a dynamic activity, and this has protective effect on the heart and the lungs. An anaerobic exercise in which you use the energy provided by glycolysis and stored phosphocreatinine is not needed in order to maintain your weight or maintain your heart and lung function. Aerobic activity include brisk walking, dancing, jogging, bicycling, skating, swimming, snow shoveling, lawn mowing, leaf raking, and vacuuming. What is moderate intensity exercise? You need to reach at least 3 to 6 metabolic equivalents of physical activity 3 mets would be canoeing or rowing lightly or walking 2.5 miles an hour on a firm surface. 4 mets would be swimming with moderate effort. 4.5 mets would be shooting basketball. 5 mets would be kayaking, and 6 mets would be downhill skipping at moderate effort. This is the moderate exercise that's recommended for us to do every day. In terms of diet therapy, you don't need to do complicated calculation. All you need to do is to recommend 1,200 to 1,499 kilocalories per day for women and 1,500 to 1,800 kilocalories for men, or 1,200 to 1,500 kilocalories for people less than 250 pounds and 1,500 to 1,800 kilocalories for people over 200 pounds. All diets will produce weight loss, regardless of their macronutrient composition, if a consistent caloric deficit is achieved. So it does not matter what type of diet you follow, whether you do the Atkinson, Weight Watcher, or Ornish diet, low glycemic, high glycemic diet, etc. As long as you eat a hypocaloric diet and you sustain at least 500 calorie deficit per day, you will lose weight. What does it mean in practical terms? This is a typical meal plan for 1,200 kilocalorie diet. It's actually plentiful of food. For example, you can have cereal, banana, yogurt for breakfast, a baked chicken, vegetable, and brown rice for lunch, and grilled salmon, vegetable, and quinoa for dinner. So that's actually lots of food. What it also means is you cannot have candy bar, which is 200 to 250 calories. You cannot have pizza because it's mostly 400 to 700 calories per slice. You cannot have double cheeseburger because it's already 850 calories, or a chocolate shake, which is 740 calories. Even a hot dog in a bun is almost 500 calories. These are the typical food brought by the pharmaceutical representative to the clinic. And this was actual food that was brought to the clinic. Example, if you eat the fried chicken with macaroni, green beans, bun, and a cookie, you'll eat 1,005 calories for that lunch. On the other hand, if you eliminate the cookie and the macaroni cheese, and put some salad instead, you'll end up with 605 calories. So little things matter. And the same here, if you eat a pulled pork sandwich with potato salad and green beans and a pie, you'll eat 880 calories. Whereas, if you remove the least fat part of the bun, remove the potato salad and the dessert, you'll actually cut your caloric intake to less than 50% of what you would have otherwise eaten. What about medication? Medications is directed towards the satiety and hunger center of the brain, and there's afferent signaling from our peripheral tissue that goes to the brain, and these hormones include leptin and adiponectin from adipose tissue, ghrelin, this is the hunger hormones that come from stomach, peptide YY from ileum, colon, and insulin from pancreas. All of these signals go to the brain in the arcuate nucleus of hypothalamus, and it's integrated through two set of neurons, including the POMC or pro-opioid-melanocortin or CART, cocaine and amphetamine-regulated transcript, and the neuropeptide 1 and agouti-related peptide. And with this signaling, it then goes to our hindbrain, our medulla, carrying the message to our peripheral tissue, back to the peripheral tissue to control our food intake and energy balance. So you have all this peripheral signal going to the brain, and then the signal from the hypothalamus go to the medulla in the nucleus tractus solitarius, and you have those vagal signaling that control your feeding, gastric emptying, and metabolism. These are the available medications approved by FDA for treatment of obesity. Bensphentamine, diethylpropion are similar to phentermine. Liraglutide or Saxenda has been approved for this is the latest medication that's approved for use in treatment of obesity. This is an acylated human GLP-1 receptor agonist, which acts mostly on the tractus solitarius of the medulla to control feeding. Lorcaserin is a serotonin receptor agonist, a serotonin type 2C receptor agonist, which affect the POMC activation. Naltrexone bupropion XR is a weak dopamine agonist and a norepinephrine reuptake inhibitor. Orlistat is a lipase inhibitor, so you do not absorb the fat from your GI system. Phendimetrazine are similar to phentermine. Phentermine is probably the medication that I prescribe most. It's a sympathomimetic agent that increases norepinephrine activity in the hypothalamus, and it reduces the appetite and possibly increase energy expenditure. The side effects are dry mouth, constipation, insomnia, headache, tachycardia, and hypertension. And it's contraindicated in people with coronary artery disease, stroke, cardiac arrhythmia, hyperthyroidism, uncontrolled hypertension, and seizure. It is approved by the FDA for short-term use, so it's a 3 months use only. Again, all of these drugs are targeted towards the anorexigenic pathway and the orexogenic pathway of the brain, which we don't have time to go through. In terms of effectiveness, phentermine combined with topiramate, this combination is called Kisimia commercially, is the most effective in making people lose weight, followed by liraglutide, naltrexone, orlistat, and lorcaserin is the least effective. The Medicaid system of California will approve the use of these different medications for people with BMI of less than 30 if they have comorbid conditions, or BMI of more than 30 if, and also a different type of bariatric surgery. This is their assessment on what is effective. If they're moderately certain, these gray boxes, if they're moderately certain about the effectiveness of the medication, then they will pay for it. Unfortunately, all of these medications are specifically excluded in Medicare payment. Medicare specifies that all this diet pill will not be covered. Phentermine is inexpensive. It costs about $15 to $20 a month. while all of these other recently approved drugs cost about $200 a month. So patient has to be willing to pay for it. Liraglutide costs about $1,000 a month. What we can do, though, in terms of limiting the behavior, the treatment, is the sugar-sweetened beverages. Sugar-sweetened beverages is a huge contributor to obesity, especially in the minority population. You would be surprised how many of my patients are drinking 2 liters of Coke a day. You know, in 1965, 2.5% of the total energy input comes from sugar-sweetened beverages, but now about 9.1 to 9.5 of the total energy input comes from sugar-sweetened beverages. And this starts very early in life. About 22% of toddlers between 21 to 24 months consume at least 1 sugar-sweetened beverages per day in the form of fruit juice. So, the American Heart Association recommends not getting more than 5% of your energy intake from sugar-sweetened beverages, and to just drink skim milk, water, or very little, 100% juice. So that's the general recommendation. Small changes do add up. The problem with sugar-sweetened beverages is people do not consider them as food. So many people will just consider solid food as real food. And nobody said, I had a meal of Coca-Cola, really. So it tends to be neglected in terms of calorie count. So if you drink a diet drinks over 1 can of 12-ounce Coca-Cola, if you'll lose actually 15 pounds a year. If you skip the candy bar every day, you'll actually lose 26 pounds a year, and so forth. And a lot of my diabetic patients actually eat 2 scoops of ice cream per day, and they keep on telling me it's low sugar ice cream, and yet they will gain 33 pounds a year. And if you drink 2 beers a day, you will gain 31 pounds a year. So little changes do matters. So on the controversies of whether we need to eat 3 meals, 6 small meals, or we can get away with 2 meals, there's a lot of study on whether skipping breakfast actually is harmful in terms of making you gain more weight. And the association of breakfast skipping with increased body fatness is consistent across cultures and is well established. This has been shown in the European population, Asian and Pacific region, and in the United States. What has not been considered is most people who skip breakfast do not have enough sleeping time. The reason children do not eat breakfast is because they sleep late. Or in the adults, they skip breakfast because they did not have enough sleep. Turns out the sleep part, the duration of sleep, has a lot to do with control of the hedonistic or the limbic system of the brain. Therefore, it's actually the other factors that really matters in terms of in relation to skipping breakfast. There's a huge experiment going on when the USDA starts supplying food for breakfast in children. This food program started in 1999, and the data between 1999 to 2010 show that children who eat breakfast actually has a higher rate of obesity if they are below poverty line. And it does not change the amount of food that they will eat for lunch. So large prospective studies also showed eating breakfast does not have long, strong association with weight change over time. Actually, breakfast skippers tend to eat less calorie if they do not compensate it with other forms of eating, usually snackings. However, it has been shown that skipping breakfast is associated with decrease in spontaneous physical activity and do adversely impact insulin sensitivity. Whether in the long term it will lead, this decreased insulin sensitivity will eventually translate to obesity later on is uncertain. And there are a lot of data also, trying to examine what types of breakfast we need to eat in order to prevent obesity. Consuming eggs versus bagels or high-fiber food at breakfast will only reduce energy intake at lunch. This has only been shown in overweight and obese subjects and has not been shown in lean subjects. What about the eating pattern? There's a tendency to think that eating 6 small meals may be more beneficial than eating 3 regular meals. As it is, somebody is tracking our eating habits. So in men between 1971 to 2010, about 90% of men eat snack once a day. But the 3 meals a day regimen has been decreasing, so skip no meal people has been going down. And more often than not, it's the lunch that most people skip, followed by skipping breakfast. That's the second most meal that is skipped. And very few people skip dinner. And it so happened that these same trends occur in women. Again, most people are eating 2 meals, regular meals, rather than 3 meals a day. And again, most of the time, they're skipping lunch and followed by skipping breakfast. What happened is Enhanced 1 did track the caloric intake on people who eat snacks all the time. And these are not the data on people who were put on hypocaloric diet. Turns out the more meals you eat, the greater your energy intake will be. So for people who are not under hypocaloric diet regimen, eating snacks is actually very harmful. What about skipping? This is a Japanese study showing that skipping breakfast, this is their BMI, and these are the odds of developing increasing weight gain. They show that skipping breakfast do contribute to the higher incidence of obesity in Japan, which is BMI of more than 27, and eating late, this is skipping breakfast, eating late dinner also contribute to increasing weight gain. If you skip breakfast and then eat late dinner, then your possibility of gaining weight is much higher. In terms of behavior treatment, we teach our patient to reduce exposure to problem food. For example, if they're addicted to candy bar, they should not buy the candy bar. Avoid fast food restaurants or eat all-you-can buffet because they really eat all they can. Store foods out of sight, so you tend not to remember what to eat unless the food is staring at you. Control portion sizes, avoid snacking while engaging in other behaviors. It has been shown that most of the snack food are caloric dense. People tend to be more conscious of what they eat when it's a regular meal. But what they eat in between the meals, people do not pay enough attention to it. Avoid high-risk situations like winter eating and holiday eating. And know that physical activity can be performed in short bouts. For example, 10 minutes of intensive exercise, moderate intensity exercise times 3 is as effective as doing the exercise in a 30-minute block. And the ultimate goal is to walk about 10,000 steps daily, the equivalent of 4 to 5 miles a day. What about the relationship between intelligence and obesity? Nobody would dare to do this study in the United States, but the data do come from a lot of European countries. This is a UK study showing the IQ test as age 7 is highly correlated with the degree of obesity at age 51. So the higher the IQ, the lower the rate of obesity. This has also been shown in Belgium, Swedish study, and many other countries. Therefore, we need to pay a lot of attention to people who are schizophrenic, who are not highly educated because of their mental capacity, and reinforce the treatment early on. So in summary, weight loss of 5 to 10% is only produced by comprehensive behavioral intervention. This is intense lifestyle modification. It cannot be induced by just what I said to the patient, try to walk, here's your 1,200 calorie diet, and it has to be a hypocaloric diet. It's very easy to eat above your required calorie. Exercise is needed and behavior therapy. And diets of varying macronutrient composition are all successful if they induce appropriate energy deficit, and again, 1,200 to 1,500 kilocalories per day, 1,500 to 18 kilocalories per day for men. And physical activity alone is of limited benefit for inducing weight loss, but it's necessary to facilitate long-term weight management. And use of pharmacotherapy, meal replacement, intense lifestyle modification, surgery should be considered with increased obesity complications. Thank you for your kind attention.
It's interesting to me that obesity, like other chronic illnesses, is easier to prevent than to treat effectively. The slide that you presented that had multiple colors from the AHA that had, as you get worse, you intensify treatment, seems to be not the appropriate approach, considering that. I would argue that based on what you just said, we should have intensive treatment. Before, it's like buying a car insurance after a car accident. No? So here we're treating obesity once it develops. What do you think about that? How intense should the treatment be in those predisposed for or have prediabetes or something like that, as opposed to waiting until that BMI keeps on growing?
Actually, that's why there's a lot of work by the government in trying to prevent obesity in the children. There's at least over $1 billion a year that is being spent to prevent obesity in children. But they're not sure that the direction is correct. For example, thinking that skipping breakfast is harmful, they started the school breakfast program. It turns out not to be really helpful because apparently children think it's free food, so they eat a lot of it, So there is a lot of policy decision that has to be done nationally. New York State tried to prevent obesity by doing the sweetened beverage tax. It was turned down by the Supreme Court of New York State. So there's a lot of government policy that's not working right now. So it's up to the primary care physician to do all this work. It's a lot of work, actually.
I have a question about the intensive therapy, the weekly meetings and things. So for our particular situation, I'm not sure that's practical. Do programs like Weight Watchers that have the weekly?
Yes.
I think the online things, but does that help also?
Yes, it's actually highly recommended to be involved in such a program, but it tends to be expensive. Weight Watchers will ask you to pay for food. It's about $125 a week that they have to pay for the meal replacement therapy. Most of my patients are in that program. There is increasing coverage in the private insurance, but Medicare will mostly cover only laparoscopic gastric banding. That's why they convened that 5-year study in order to determine what Medicare will pay. But they will not pay for any of the medications, not at all. You cannot appeal that.
I have a question about the drug, Melvin. It's a drug to cure diabetes. And you know, the people who are overweight always with insulin
resistance.
So how about the people who is overweight but with a lower BMI, lower than 29, has the drug Melvin?
There is specific features for some of these drugs. For example, if you have food addiction, it's better for you to take the topiramate, etc. But none of these drugs will be prescribed for people with BMI less than 25. Nobody would prescribe it. I will not prescribe it, you know. So, but now the drug development is gearing towards the biologics, you know. There's now in clinical trial a biologic agent like Humira that you have to inject every week. And it's an antibody against one of the methylmalonic acid, and it's coming to the market soon, you know.
That's good.
Just a general question: are diet sodas really safe? Is there any?
No, diet soda is good for sugar control if they have to have it. However, there's a lot of evidence showing that drinking diet soda will increase your appetite on the next meal, because the center of the areas of the brain that require sugar will think they're starving. So there's evidence showing that you'll eat more, actually.
I can vouch for that. Some of you know that my interest in the area of fibrosis, and I always think about fibrosis, something that when we lived in pain, we needed, because we would die from bleeding out to trauma or from infection. So we can fibrose it to wall the parasite off, or we can scar it to prevent it clotted and bleeding. And I wonder, and we have evolved very quickly, technically, but our genes and our bodies have not evolved to diminish that from our armamentarium or tools to address disease. And I think calorie consumption and development of fat storage and so forth is an evolutionary trait that we have sort of, we are evolving against that trait. Mm-hmm. By computers, by sitting down all the time, by not doing the things that would keep us moving in the path where we needed this. It seems to me that the approach to address an evolutionary established trait as a disease, it must be quite incredible.
Right.
That challenge is incredible.
Yeah.
And so understanding all the biology behind all this might be quite